Thank you very much. So I'm going to focus this talk and this overall presentation with my co-presenters on interstitial cystitis and a recent problem, recently discovered problem of Pentosan Maculopathy, what urologists and ophthalmologists need to know. And so I'm joined for this presentation by two expert ophthalmology faculty. First is Randy Glickman, who is a basic science retinal researcher at the University of Texas Health Science Center in San Antonio. And Randy and I have done previous work together. And then also, in particular, welcome to Dr. Nieraj Jain at Emory Ophthalmology in Atlanta. Dr. Jain is a rising superstar in the retinal field and has published many of the papers which are germane to this topic. So thank you to the ophthalmologists who are on this conference as well. So what I hope to do, let's see if I can move my, what I hope to do is go through a number of points here with my colleagues, and that is I'm going to basically talk primarily to the ophthalmologists who are on this conference and give a very brief overview of interstitial cystitis pathophysiology, how bladder epithelial permeability leak leads ultimately to neural upregulation, and why trying to replace this glycosaminoglycan layer of the bladder epithelium is an important strategy. And then review briefly the data on Pentosan and its efficacy. And then I'll turn it over to Dr. Glickman, who will help us as urologists understand where in the body the retina is, and then where within the retina the macula is, and some macular physiology, which is completely unknown to this audience. And then to Dr. Jain, who will describe the findings of Pentosan maculopathy and how we should screen for it. And then lastly, I will talk about just a few scenarios I am encountering in my practice and how I'm dealing with this issue. So by way of introduction, interstitial cystitis is a common problem. The latest prevalence estimates put this at 7 million women and 1 million men in the United States, which would translate to roughly 1 million women and men in Canada. Most studies show that the quality of life is comparable to unstable angina or relapsing multiple sclerosis. These are miserable patients, and the average patient goes 4 to 7 years and sees 2 to 8 physicians before the correct diagnosis is made, so that generally these patients are frustrated by the time they get to your door. Now, our chapters in our textbook on interstitial cystitis, I think, are misleading. They often give the impression that nothing is really known, there's nothing but controversies in the literature, and that this is an inflammatory disorder. So having taken care of this problem for 24 years and seeing over 3,000 patients to my estimation, I think the thing which I've learned over time is that this is not primarily an inflammatory disorder. It behaves as a hypersensitivity disorder. And just to underscore that point, the very first description of interstitial cystitis goes back to an 1836 medical textbook where the physician called it tic douloureux of the bladder. That is, he likened it to trigeminal neuralgia. I'm just going to go through one of the controversies that really should not be a controversy, and that is the role of the bladder epithelium, and specifically the bladder mucin or glycosaminoglycan layer. So on the left is a paper from Curtis Nickel showing the luminal surface of the bladder, and you see the umbrella cells at the top layer of the transitional epithelium. And then you have this highly arborized thick coating of GAG or mucin, which is hydrophilic and is also electrically charged. And this acts as both a permeability barrier and an adhesion barrier. It acts to protect the bladder epithelium. And when you think about this, the bladder has this difficult chemical challenge that it's constantly saturated with water and chemicals, and you don't want to equilibrate across the epithelium. You want to be able to excrete what the kidneys have excreted. Now, on the right is a paper from the group at Oklahoma, And they looked at a group of IC subjects versus controls. And what they demonstrated is in, I think it was 27 IC subjects versus 12 controls, that when they did special stains of the epithelium, you have a representative picture on the left of normal epithelium and on the right abnormal staining that was seen in 90% of the IC subjects. Here are two additional papers on the issue of permeability. And so on the left is a paper from Parsons in which he put radioactive labeled urea in the bladder for 40 minutes and then measured the amount of absorption. And you can see that after 40 minutes, 25% of the urea load was reabsorbed on the IC subjects, but in the controls, only 4% was reabsorbed. And the assay limit was 4%. So this is effectively zero. They then put a 5-minute protamine wash into the control subjects and re-challenged them with urea. Now, protamine sulfate is a quaternary amine. It disrupts the surface mucin coating, but leaves the underlying cells intact. So when they re-challenge after the protamine, they go from 4% to 22% reabsorption. In other words, you can take a normal bladder and turn it into an IC-like bladder by disrupting the surface glycosaminoglycan layer. Now, again, our literature would have you believe that the data is inconclusive. And to prove this point or to claim this point, everyone quotes this one paper from Chelsky and colleagues in Philadelphia. And this was a paper in which they did something similar. They put DTPA in the bladder of IC subjects and controls for 30 minutes and then took venous samples to measure the amount of radioactivity they recovered. And effectively, what they showed was 86% increase in DTPA recovered in IC subjects versus controls, p-value 0.07. So they rejected the null hypothesis, saying there is no evidence of permeability going on here. This is a fundamental misread. So I threw this paper at a statistician who told me that with an N of 19, they had a statistical power of only 28%. In other words, with a 1 in 4 chance of finding a difference, they found an 86% difference with 93% confidence. To me, the real take-home of this paper is there likely is a real problem here, but they just didn't study enough patients to prove the point. Now, once you allow for this permeability issue, you then get solute crossing the epithelium, and so potassium is one of the guilty culprits here, which will injure smooth muscle, it will depolarize sensory nerves, and it leads to mast cell activation. Mast cell activation leads to histamine release, as well as neurokinins and nerve growth factors, so you increase your nerve cell density. So the end result of this process is neural upregulation. Once you have neural upregulation, you're off to the races, because what patients are really describing is hypersensitivity. They tell you that rather than have the normal state of affairs where they feel their first urge to void at 100 cc's, second urge at 180, and their bladder capacity at 250, that they have their first urge at 25 cc's, second urge at 50, capacity at 75 cc's. No wonder they describe urgency, frequency, and nocturia. But additionally, patients get to a point of neural activation where the nerves change the character of the signal. And so what is normally a non-painful event, such as bladder filling, is suddenly painful. And so this is a phenomenon in the literature called allodynia. And so patients will describe that a bumpy car ride hurts, wearing their belt over their lower abdomen hurts. And so they're giving you all of these unusual pain descriptors, which most of us roll our eyes because we think this makes no sense. And typically our response or our felt sense with these patients is, you know, just from a gut check within 20 seconds that this is an IC patient, because they're like this cartoon woman saying, I hope you're not going to be like the 20 incompetent doctors who couldn't find anything wrong with me. So once you accept that this is the epithelium is a problem, it's a logical approach to try to address the epithelium. So I'm just going to touch upon a couple of Pentosan papers that got its approval. So the first is an older paper in which there were 4 centers recruiting 148 patients. treating with Pentosan 300 milligrams a day versus placebo. All patients had a reduced anesthetic capacity. Very few of them had these severe Hunter ulcers. And at 3 months, the patient rated improvement, that is a greater than 50% global improvement score. There were 32% responders in the Pentosan treated group versus only 16% in controls. And so there were 8 randomized control trials in our literature. 6 are positive. All 6 show effectively the same finding, that at 3 months, the responders are about 35 to 40%, and placebo is 15 to 20%, and all are statistically significant. Because of this general trend of statistical significance, but relatively low efficacy, there was another trial called the dose ranging trial that was a randomized study. Curtis Nickel was the first author, in which we tried 300 versus 600 versus 900 milligrams a day, hoping that a higher dose would lead to a better response. What was really instructive of this paper on the right was, rather than find greater efficacy at higher dose, we discovered that the longer you treat patients, the better they do. So at half a year, the response wasn't 35 or 40%, but it was 60%. This was an intent to treat analysis, so it wasn't as if the success was on the basis of dropouts. In a follow-up paper from this one, Curtis again published a paper showing that if you had symptoms for only 6 months versus over 24 months, so if you were treating early versus treating late, you had a much better response as an early treated patients. So in other words, what we have is a state of affairs of, these are miserable patients, there's a lot of them out there, and that if we treat them early with Pentosan and we treat them for a long duration, we should have a good success rate in terms of controlling their bladder symptoms. And the drug has a stated side effect of 4%, and most of the side effects are minor, except now we have evidence that perhaps this isn't as benign as we thought. And so with that, I'd like to turn the mic over to Dr. Glickman, who will help us understand what the retina and macula do.
Well, thank you, Joel, for that introduction. So good morning to all of you in Vancouver. My regret is that I can't be there to talk to you in person, but hopefully we can get the message across remotely. And I'll say my comments are mainly directed at the urologists. To the ophthalmologists in the audience, please bear with me, and hopefully it's not too repetitious for you. So Joel asked me to give an overview, a review, if you will, of basic retinal physiology and organization. And so I will do that, and also make some hypotheses about where the Pentosan, if it is indeed the underlying cause of this maculopathy, what mechanisms and cells it might be affecting. So to start with the basics, here is a transected human globe. This is a pathology specimen from our eye clinic. This eye was enucleated because of a uveal melanoma, and this is the normal side of the eye. It's fixed, so it's not as transparent as it would be fresh, but we can see the transparent cornea here where light enters the eye. The iris would be here. That's the contractile structure that regulates light entering the eye, the physiological lens that focuses light on the retina. And the retina, you can see, lines the back of the eye. Normally, it would be transparent, but because the eye is fixed, we can see it's kind of cloudy. And then here's the stump of the transected optic nerve. If we look inside the eye with the fundus camera, we'll see a view something like this, and there are a number of landmarks that you'll hear referred to later by Dr. Jain, I'm sure. But probably the most prominent landmark is the optic disc here, which is formed by the exit of the optic nerve that contains all the axons from retinal neurons that are traveling up to the central visual tracts. And also traveling with the optic nerve are vessels entering the eye, and we can see the arteries and veins that form this arcade around the central part of the retina here. And in that center is the foveal region, which is the part of the retina that is specialized for high acuity vision. And we'll look at the fine structure of this in the next slide. But this general region here is what clinicians will refer to as the macula. And anatomists might have a different view of macula, more centrally around the fovea, but for today's purposes, this is the macula of the retina. Now, if we look at this macular region, This diagram here will show how it's classified in terms of foveal and extrafoveal regions. This front view here is the what you see if you had a cross-section of the retina. And so in the very center, we have a little pit here, depression. This is the foveola. It's thin because cells other than the photoreceptors are pushed out. And this is the most highly resolving part of the retina. Around that is the part marked B is the entire fovea. And you can see these numbers down here will indicate the size in millimeters of this region. So we're looking, the fovea itself is a region of about 1.5 to 2 millimeters in diameter. Beyond that, more eccentric positions is the parafovea and the perifovea. And just as a little reminder, in terms of visual angle, about 1 degree corresponds to subtense of about 300 microns, that is 0.3 millimeters on the retina. So if you look at the retina in high magnification, this is a drawing, not a micrograph, but very good drawing. You can see that the retina is a highly layered structure. And mainly what I want to point out here, without going into too much detail, is the structure of the photoreceptors that are down here. They are cells that have an inner segment that contains the nucleus and an outer segment that contains a lot of membranous discs that we'll see a little bit later. And this is where the visual chromophore is located that absorbs light and triggers the visual transduction process. Also very important for today's discussion is the close apposition of the photoreceptor outer segments with the retinal pigment epithelial cells down here. And the RPE cells and the photoreceptors have a very tight interplay that's critical for their function and survival. Below the RPE, not shown on this figure, is the choroidal circulation, which is also critical for bringing oxygen and nutrients into the retina. And just for your orientation, the pupil would be up and towards this end, and light would travel through the eye and actually through the back of the retina, or I guess you could say the front of the retina, and all the way through the layers until it reaches the photoreceptor. So that might seem a little backwards, but that's how it works. So to look at the fine structure of rods and cones, because this will be pertinent to the rest of the discussion, I think we all know that the rods are responsible for our ability to see in the dark, or scotopic vision. Cones are our daylight vision, our photopic vision. And so they have a number of structural differences that subserve these different functionalities. And what I'd like to point out is that in the rod photoreceptors, these membranous discs that fill the outer segments are free-floating. They form by outpockets or pinchings off of the cell's plasma membrane. And in the rod, they pinch off completely and become free-floating. In the cone, they form the same way, but they don't pinch off. And so they're contiguous with the cell's plasma membrane. And I'd like to propose that this may make the rods a little bit more sensitive to disruptions, because part of the visual cycle is to recycle visual pigments after it's photoisomerized by absorption of a photon. And that pigment has to be transported across two sets of membranes to get to the RPE cell where reisomerization takes place. And in the cone, that only requires one transport. And so there may be more targets for disruption in the rods. So to show you what the rods look like in high resolution, here's an EM image of a human retina. And you can see the rods and the cones are very much derived from the morphology. The rods are long and thin and slender, and the cones are stockier, conical, and shorter. And this is seen even better in a three-dimensional view from a primate retina in scanning EM. And so we can see the cones here with their stockier, conical inner segments and short outer segments, and the rods are long and thin in their inner and outer segments. So the RPE cells, as I mentioned, are very closely apposed to the photoreceptors, and they fulfill three critical functions for photoreceptor function. One, they serve as the gateway between the choroidal circulation and the photoreceptor cells, and they are responsible for transporting essential oxygen and nutrients into the photoreceptors, which are very metabolically active cells. In fact, the most active cells in the retina in terms of metabolism and oxygen uptake. They're also critical for recycling the visual pigment, and I have a slide showing that in overview. And they also aid in the process of disc shedding. So the photoreceptors continually cast off their outer segment discs because they are subject to a lot of oxidative stress. And the RPE cells take up those segments and degrade them back to their basic components for reuse. And this can be seen very nicely in this EM. Here's the rod outer segment with the discs. This is the RPE cell. We can see melanin granules here. And then here's a phagosome showing taking up outer segments that are in the process of being degraded. So this shows the process of disc shedding in detail. So I mentioned the pigment cycle, the visual cycle. This diagram shows this in overview. Here's the photoreceptor outer segment. You can see the discs here. And you'll notice this little chemical structure is 11-cis retinal. This is the actual chromophore that absorbs light. It's the only light-sensitive molecule in the eye that's photoactive in the visual process. So after it absorbs a photon, it photoisomerizes to the all-trans form here, which then is picked up by a binding protein transported through the interphotoreceptor matrix into the RPE cell, where through a series of linked enzymatic reactions, it's reisomerized into 11-cis and transported back into the photoreceptor for reuse. So this is the visual cycle and obviously critical for photoreceptor function and mediated by the RPE. So Dr. Teichman mentioned the glycosaminoglycans as a possible target for the Pentosan drug. And it happens that these GAGs are also expressed by photoreceptors and RPE cells. And importantly, they're also part of the interphotoreceptor matrix structure, which is clearly key to getting the function in the visual cycle. It also, the drug may also inhibit growth factors, in particular fibroblast growth factor, FGF. And these actions have particular consequence for the retina. This immunohistochemical slide from the paper by Clark et al. Does show several GAGs in the RPE cells and photoreceptor matrix. The green staining indicates the glycosaminoglycan. So here we see it, this heparan sulfate in the photoreceptor matrix here, and then in the RPE cell layer. Here's chondroitin sulfate. Again, we see this pattern of heavy staining in RPE and interphotoreceptor matrix. So these GAGs are definitely in the retina and serve an important function. I mentioned growth factor effects of the drug, and the RPE cells are heavily involved in growth factor trafficking, as shown in this diagram here. And I'd like to point out that FGF, which is singled out as a potential target of the Pentosan, is involved in this trafficking, and its role is in the stability of the photoreceptors. So if this is interrupted, then there are probably deleterious consequences on the photoreceptors. Finally, I've noticed that many descriptions of the maculopathy indicates that it seems to form in the para or perifoveal region and then ultimately moves into the fovea. And one possible reason for this is the distribution of these photoreceptors. This figure is from the classic paper of Osterberg from 1935, who mapped the density of photoreceptors in the retina. So you can see that in the fovea itself, indicated by eccentricity of 0, the cone density reaches a peak and then falls off to a lower density throughout the rest of the retina. The rods reach their peak density in the perifoveal region and fall to 0 in the fovea. They're not found in the fovea at all. So if rods indeed are more sensitive to this drug, then we may see the indications of that in the macular changes in the perifoveal region, finally migrating into the fovea as the condition progresses. So just to wrap up what I've said, this pentosan polysulfate may interfere with elements critical to the health and function of the RPE and photoreceptors, namely with the GAGs and FGF. And without the support of the RPE, the photoreceptors will definitely lose function and ultimately degenerate due to the loss of growth factor signaling and disruption of the GAG layer. So really the take-home message from my comments are this, that sick RPE invariably leads to loss of the photoreceptor function. So with that, I'll turn the floor back to Dr. Teichman.
Well, I really appreciate the invitation to talk about this work, Dr. Teichman. I really appreciate it. And Randy, those are some beautiful images of the retina and really dovetail well with what we're going to talk about now. So I'm in Atlanta at Emory University. I'm going to give you a brief overview in the next 10 minutes of what I think are some key clinical pearls, both for ophthalmologists and urologists when we talk about pentosan polysulfate maculopathy. So how did this come about? So initially what happened is I had seen this patient who was referred to me with a clinical diagnosis of pattern dystrophy. And she had some unique pigment clumps in the macula. This is the fovea right here. And we did some other imaging tests of her retina and saw some other peculiar changes that didn't quite fit a diagnosis of pattern dystrophy to me. And it brought to mind another similar patient I'd seen who had also been on had a similar past medical history and was on similar medications. And I noticed that this patient was taking this drug, pentosan polysulfate, which at the time I wasn't really familiar with it. So what we did is I went to the electronic medical record and I was able to search by drug. I'd never done this before, but amazingly I was able to do it, and it returned a list of patients that we had seen at our institution on the drug. And I recognized a number of the names on that list because some of them were mine. When we looked into their the charts, we found 6 patients with this very peculiar pigmentary disturbance in the macula with quite similar findings when we looked at different imaging modalities of the retina. And we reported these findings in just 3 years ago. Well, a key question that we had from the outset was it this drug, pentosan polysulfate, or was it some other confounder or covariate that was responsible for this unique macular disease? Was it a indication bias? Was it the indication for therapy, this interstitial cystitis, that may be responsible for the retinal findings? And you all know better than I that patients with IC can have other comorbid conditions, and perhaps there is some common link between the two. Or was it one of these medications? And I noticed a number of our patients were on many medications for other health problems. And so we did a study where we looked at all the patients at our eye center that had a diagnosis of interstitial cystitis and had masked image graders review their ocular fundus imaging and identify cases of this unique pigmentary maculopathy. And then we tried to discern if there were any other confounding variables here. And what we found was that exposure to this drug was the only risk factor for manifestation of this maculopathy. In fact, we didn't find a single case of a patient with IC who had not been on the drug and still developed this maculopathy. It was only present in patients who had prior exposure to the drug. So the next question is there a dose-response relationship, and what is the prevalence of this condition? And this is a study that was done at the Kaiser Health System in Northern California, where they looked at patients who were on this drug with a cumulative exposure of over 500 grams. That's about 4.5 years at the standard daily dose of three pills daily. And what they found in increasing tiers here of exposure, that at the 500 gram to 1,000 gram exposure level, you had about a 13% prevalence of this maculopathy. And there was a dose-response relationship. Once they got over 1,500 grams, which is about 13.5 years on the drug at a standard dose, they're almost approaching 50% presence of this maculopathy. So the next thing we did is we did a retrospective study looking at a number of other institutions to just kind of describe the clinical features of this condition. And this will be a little more helpful to the ophthalmologist to understand what we're looking at. So the first thing is that the ocular fundus findings are quite subtle when we look in the back of the eye, except in advanced cases where they develop this atrophy. And this is what Dr. Glickman was referring to, is when the retinal pigment epithelium atrophies or basically dies off. That's a monolayer of cells. And once that happens in this area that's kind of white, it's kind of kidney bean shaped here, once the RPE is gone, it's basically an absolute scotoma, meaning the patient has no retinal sensitivity in these regions. And so this is a kind of a devastating outcome. What stands out, though, is when we do this imaging called the fundus autofluorescence imaging, the findings are much more apparent and really characteristic of this condition. And then one other thing I want to point out is this patient who had autofluorescence imaging over here, near infrared reflectance imaging of the retina here, and was called an optical coherence tomography, basically a cross-sectional scan through the macula on the bottom slice here. And this is this is a set of images that I think is most useful for detecting this maculopathy. And the reason I'm highlighting this case here is this patient looked almost completely normal, except this imaging modality here, the near infrared reflectance. We see some very subtle stippling in the reflectance pattern here. And I do believe this imaging modality may be the most sensitive for disease, although not necessarily specific, whereas autofluorescence imaging may perhaps be the most specific and is really essential to diagnosis. So for the ophthalmologists, how do we differentiate this condition from other common diseases? Well, AMD, or age-related macular degeneration, is the most common cause of vision loss in older American adults. And we're going to see that a lot in this patient population. And so I think it's very important that we understand how to differentiate them. One of the key findings is in AMD, we have drusen appearance of drusen underneath the retinal pigment epithelium. They can also appear on top of the RPE in what we call subretinal drusenoid deposits. In this condition, PPS maculopathy, we see lesions that appear to be intraepithelial or at the level of the retinal pigment epithelium. These are pigment clumps that cast a shadow onto the underlying choroid. And I think that can be quite helpful in differentiating early PPS maculopathy from AMD. In more advanced PPS maculopathy, usually it's pretty obvious on the autofluorescence image. Another set of conditions that can look like this are inherited retinal diseases, or retinal macular dystrophies to be specific. And I just want to highlight one feature here for the ophthalmologists in the audience. In PPS maculopathy, you can have, when the disease comes around the optic nerve, you have this hypoautofluorescent ring around the optic nerve. And that is really different from typical macular dystrophies, where we have isoautofluorescence, or sparing of normal autofluorescence signal around the optic disc. And these are three different forms of macular dystrophies, and we found that to be pretty characteristic. And one of my retina fellows reviewed all our cases. He was masked to drug exposure, and he did really well at being able to differentiate PPS maculopathy from other pigmentary maculopathies. So how does this progress? Well, in this particular case, we see that from October 15 to August of 16, over 10 months, there was quite impressive progression of disease just over a short time period. This patient was on the drug throughout this time frame here. What happens if they stop the drug? I'm going to show you a short video of what happens when patients stop the drug. And this is 8 months before she stopped it, 4 months later, and 11 months later. And I'm going to play it again. I want you to notice these areas of atrophy. So these are the absolute blind spots here. And even after the patient stopped the drug, these areas of atrophy continue to enlarge. This is only about a year of follow-up after she stopped. We've followed other patients for a greater time period, and we see this continue to progress. Hopefully, eventually, the rate of progression tapers off. Unfortunately, we have not seen any patient where the disease just goes away once they're off the drug. So this next two slides, I think, are really important for the urologists in the audience, for you to appreciate how this impacts our patients functionally. So one of the things we noticed early on is that when we do visual acuity testing, we use this eye chart. Our patients often are able to read the eye chart fairly normally. They can read the 20/20 line or the 20/25 line, which is thought to be normal. In contrast to that, our patients described much more severe visual dysfunction. They were really suffering visually, and it wasn't captured with the eye charts. So we did this prospective study where we used a number of other devices to assess visual function in greater detail. And I don't have time to go into great detail, but I'm just going to show you, just throw up this slide, just of all the modalities that we looked at, looking at patients with moderate and severe PPS maculopathy. And it became quickly apparent that we were detecting severe visual function disturbance with these other testing modalities that was not captured with visual acuity testing. One key symptom that I want to highlight is dark adaptometry. So patients, our visual system has great dynamic range, the ability to adjust to very bright sunny days and dim lighting indoors. In these patients, it takes an incredible amount of time for them to adjust from bright light to dim lighting. That's called dark adaptation. And that's often a very early common symptom they may explain to you, that they're just having a hard time coming indoors and being able to read in the dim light. This other testing modality is a patient-reported outcome measure called the Low Luminance Questionnaire. And this is this test, the results we got from this study were the worst scores that I could find from any study using that Low Luminance Questionnaire instrument. So what do we do for screening? I like to keep things really quite simple. I recommend patients get screening at the baseline visit and then annually thereafter. So basically within 6 months of starting the drug, with a fundus exam and these different types of retinal images. I do think that retina specialists are most comfortable acquiring these. The one imaging modality here is the near-infrared reflectance, is not as widely available as the others. I'm going to end here, but if you have questions, if you're seeing a patient in your clinic and you just need a quick reference, there's a page that you can search on Google, the iWiki page on Pentosan polysulfate maculopathy that has a lot of these details here. Again, I want to thank you for allowing me to discuss the work, and thanks to my collaborators.